everyone, my name's Chantal Maloney and I'm one of the nurses from Melbourne Sexual Health Centre, and today we're talking about STIs and how do we know if we have an STI. Asymptomatic screening. So the fourth National Sexually Transmissible Infection Strategy, which runs from 2018 to 2022, identified some priority populations who we should be focusing on when it comes to asymptomatic screening. So young people between the ages of 15 and 29, Aboriginal and Torres Strait Islander people, gay men and other men who have sex with men, sex workers, culturally and linguistically diverse people, travellers and mobile workers, and people in custodial settings. Now, I think there's two other populations worth mentioning here as well, two other vulnerable groups, and they would be people who inject drugs and people living with mental illness. What type of STI is it? It helps when we're talking about STIs to break them into different categories, and there are three different categories: bacterial, viral and other. Generally speaking, we find that viral STIs are more prevalent and more likely to be lifelong, whereas bacterial are generally curable and can be asymptomatic. With bacterial STIs, we're mainly looking at Chlamydia, Gonorrhoea, Syphilis and Mycoplasma genitalium, or MG. And for viral STIs, we're looking at HSV or Herpes Simplex virus, HPV or the human Papillomavirus, Molluscum contagiosum or MC, and HIV. Now there are other STIs, but these are the main ones that we're going to focus on today. With bacterial STIs, we're mainly looking at Chlamydia, Gonorrhoea, Syphilis and Mycoplasma genitalium or MG. And for viral STIs, we're looking at HSV or Herpes Simplex virus, HPV or the human Papillomavirus, Molluscum contagiosum or MC, and HIV. Now there are other STIs, but these are the main ones that we're going to focus on today. Chlamydia. Chlamydia is the most common STI reported in Australia, and it affects a lot of young people. Chlamydia can infect the cervix, the urethra, the throat, the rectum and the eyes. It can be transmitted during vaginal, anal and oral sex, when a condom isn't used or a condom's not used correctly. Vertical transmission from mother to baby is possible, and this usually presents as conjunctivitis or pneumonia. It is a notifiable infection, which means that it needs to be notified to the Department of Health, and it's very simple to test and treat. So we can test for it in the urine or on a throat swab, rectal swab, cervical swab or vaginal swab. And it's important that contact tracing is done. So we need to notify partners so that they can be tested and treated as well if they need to be. This slide looks at chlamydia diagnosis at Melbourne Sexual Health Centre by year. And as you can see, if we're looking over a 10-year period, we've gone from 1,052 in 2009 through to 3,644 cases in 2019. So a huge increase, and this is partly because there's more awareness around chlamydia and we're testing more, but also that there is more chlamydia around. Chlamydia and symptoms. When we're looking at symptoms with chlamydia, we know that around 80% of women will not actually have any symptoms when they have a chlamydia infection. And that's why asymptomatic screening is really important, because many women with chlamydia will have no idea that they actually have the infection. When women do present with symptoms when they have a chlamydia infection, they usually are dysuria or burning when they urinate, lower abdominal pain, or discomfort with sex, and this is usually a deep pain, a deep lower abdominal or pelvic pain with sex, not usually pain around the vagina or inside the vaginal area. Irregular bleeding, cervicitis or inflammation of the cervix, and you might notice this if you have a speculum inside the woman and you're looking at her cervix. You might notice that it's red, irritated or inflamed looking. And you might also notice a purulent discharge. 50% of men with chlamydia infections will not have any symptoms either. And again, this is why asymptomatic screening of chlamydia is so important. When men do get symptoms, they usually present as dysuria or burning when they urinate. They might describe a tingling feeling in the urethra. They might have a discharge that's clear or cloudy. They might have some redness at the meatus or tip of the penis. They might have testicular discomfort or testicular swelling. Chlamydia and its possible complications. So for women, some of the complications from chlamydia can include cervicitis or inflammation of the cervix. They may get pelvic inflammatory disease or PID, an infection of the uterus and fallopian tubes. Now this can go on to cause chronic pelvic pain, tubal infertility, or an increased risk of ectopic pregnancy. So we really want to make sure that we're avoiding that as much as possible. Chlamydia can also lead to adverse pregnancy outcomes like miscarriage or premature labour. And it's estimated that about 20% of untreated chlamydia will lead to pelvic inflammatory disease and 20% of those women will become infertile. So that's quite large statistics really for something that's very treatable if we get to it quick enough. Possible complications for men who have chlamydia infection include inflammation of the epididymis and or the testes, and proctitis, which is the inflammation of the lining of the rectum. So that complication is possible if they do have rectal chlamydia. It's obviously possible for women to get rectal chlamydia as well from anal sex. So this slide gives us a visual example of what cervicitis looks like. You can see that there's a real redness and see the discharge. The cervix looks really sore and angry and inflamed in there. Chlamydia and its testing and treatment. Testing for chlamydia is very, very easy. It can be as simple as just doing a first pass urine, or you can have a swab done from the cervix. If someone was having a CST done, you could take it at the same time, or a patient can do their own high vaginal swab, an anal swab, or you can do a swab from the throat for chlamydia as well. We like to do a test of reinfection 3 months after someone has had chlamydia. That's not to check if the antibiotic has worked. We know that the antibiotic is really successful in treating chlamydia, but we also know that chlamydia is the most common STI amongst young people, particularly in Australia, and we want to make sure that that person hasn't been reinfected with chlamydia again. And this may be because they've had sex with someone who hasn't been treated. Only in rectal chlamydia do we do a test of cure or a TOC, and we usually do that 1 month after a positive rectal chlamydia result. We wouldn't check any earlier because the likelihood of a false positive, if you're going to do an earlier test than 1 month, is quite high. So we want to make sure we get an accurate result at 1 month. The treatment for chlamydia infection is very easy. It's azithromycin 1 gram orally as a one-off dose, or doxycycline twice a day over 7 days. For pelvic inflammatory disease, they need to be treated with triple antibiotics, azithromycin, doxycycline and metronidazole. If someone comes into Melbourne Sexual Health Centre as a contact of chlamydia, we usually test them for chlamydia and then send them away with an outside script. So if they do return a positive result, they're able to go and collect their antibiotics from any pharmacy that's convenient to them. And it's no sex for 7 days after treatment. So the 7 days allows the antibiotic to kill off the bacteria. And if people are not waiting the 7 days, they may be risking passing it backwards and forwards to and from one another and may have to be retreated. Gonorrhoea. Gonorrhoea is another bacterial STI, and it can affect the cervix, urethra, throat, rectum and the eyes. It can be transmitted through condomless vaginal, anal and oral sex, or when a condom is not used correctly. In Victoria, it's most common amongst gay men or men who have sex with men. Vertical transmission is possible from mother to child. And again, like chlamydia, it is a notifiable infection, so the Department of Health must be notified. And contact tracing of partners is definitely required. This slide is looking at the number of gonorrhoea cases diagnosed by year at Melbourne Sexual Health Centre. And as you can see again, numbers have gone up significantly. We've gone from numbers in the 200s right up to over 2,000s over a 10-year period. We do see a lot of gonorrhoea in men who have sex with men, and not to the same extent, but we certainly do see it in females as well now. Gonorrhoea symptoms. For women who present with symptoms and gonorrhoea infection, the main symptoms they would present with are usually unusual discharge. Sometimes it could be a yellow or green colour. Now this is not a normal discharge. They might have pain with sex or pelvic pain, or dysuria, burning when they wee, or irregular bleeding. For men with symptoms and gonorrhoea infection, they might also have a thick discharge. Usually it's yellow or green in colour. This tends to look quite different to the discharge that we sometimes see with chlamydia infection. They might have dysuria or burning when they wee, and they may have redness at the meatus or tip of their penis. Possible complications of gonorrhoea infection. For women, complications of gonorrhoea infection might include cervicitis, pelvic inflammatory disease, conjunctival infection, which can occur in neonates born to mothers with gonorrhoea infection. Adults can get this type of infection as well if their eyes are exposed to any infected genital secretions. Women can be asymptomatic with gonorrhoea infections as well. In men, it can cause the inflammation of the epididymis and occasionally the testes. It can cause proctitis if they have anal gonorrhoea infections. Conjunctival infection can occur in adults if the eye is exposed to infected genital secretions. This might occur, for example, during oral sex. Men can also be asymptomatic with a gonorrhoea infection, particularly if they have gonorrhoea in the throat. Gonorrhoea testing and treatment. Testing for gonorrhoea depends on the presence of symptoms and the risk profile of the patient. You don't test everybody in every site for gonorrhoea all the time. It depends on their risk. So that goes back to what we talked about when we were talking about sexual history taking. The patient's risk and the type of sexual behaviour that they're having will determine where we're going to be taking the test from. We can take a swab for gonorrhoea from the anus, the throat, the urethra, the cervix or the vagina, or we can just do a first pass urine. And that would probably be the easiest way, particularly for someone who is asymptomatic. NAT tests are more sensitive than culture in detecting gonorrhea. And as I mentioned before, we are seeing increased rates of gonorrhea in women over the past 5 years, alongside with seeing lots of it in men who have sex with men and gay men. We treat gonorrhea infection with an intramuscular injection of ceftriaxone mixed with lignocaine, plus 1 gram of oral azithromycin. And again, we say no sex for 7 days after treatment. Gonorrhea testing and treatment. Testing for gonorrhea depends on the presence of symptoms and the risk profile of the patient. You don't test everybody in every site for gonorrhea all the time. It depends on their risk. So that goes back to what we talked about when we were talking about sexual history taking. The patient's risk and the type of sexual behaviour that they're having will determine where we're going to be taking the tests from. We can take a swab for gonorrhea from the anus, the throat, the urethra, the cervix, or the vagina, or we can just do a first pass urine. And that would probably be the easiest way, particularly for someone who is asymptomatic. NAT tests are more sensitive than culture in detecting gonorrhea. And as I mentioned before, we are seeing increased rates of gonorrhea in women over the past 5 years, alongside with seeing lots of it in men who have sex with men and gay men. We treat gonorrhea infection with an intramuscular injection of ceftriaxone mixed with lignocaine, plus 1 gram of oral azithromycin. And again, we say no sex for 7 days after treatment. Slide 21. Syphilis is staged into 2 different stages. It's either early, which includes primary and secondary infection. That means it's less than 2 years duration and it is infectious. Or it may be staged as late syphilis, which means it's greater than 2 years but not infectious. Syphilis can be asymptomatic or symptomatic, and if a patient is symptomatic with syphilis, usually the symptoms would be a sore, which is also known as a chancre, and or a rash, fever or hair loss. After many years, untreated syphilis can be fatal or lead to chronic brain or heart disease. So it's very important that we screen for syphilis in any risk populations, because we really want to make sure that we get to it and we treat it before there are any long-term outcomes or implications of having this infection. It can be transmitted during oral, vaginal or anal sex. And sometimes it's really difficult to diagnose and interpret syphilis results. If you are finding it tricky to interpret a patient's syphilis results, please feel free to contact us at Melbourne Sexual Health Centre. We have a sexual health advice line where one of our doctors can help you to interpret a syphilis result or give you information or advice on that result. Syphilis is a notifiable infection to the Department of Health, and certainly contact tracing is required. Again, we want to make sure that we're finding everybody out there who has syphilis and we're treating them before there's any long-term consequences. This slide shows us the number of cases of infectious syphilis diagnosed by year at Melbourne Sexual Health Centre. You can see the number of cases has risen from 112 to 464 over a 10-year period. Again, we're testing for it a lot more, but we're definitely seeing epidemic proportions of syphilis currently. Syphilis notifications in men and the Department of Health. So notifications for syphilis reached a record high in 2018. A total of 1,372 cases of syphilis were notified in Victoria, compared to 1,351 in 2017 and 1,134 in 2016. Now, the majority of these cases occurred in males. 73% were men who have sex with men, 30% were people living with HIV, and 50% were reinfections. Syphilis notifications for women at the Department of Health. There has been an increase of notified syphilis cases in women over the last few years. So initially accounting for 9% of cases in 2016, increasing to 11% in 2017 and right up to 12% in 2018. The increase of syphilis in women of reproductive age is a particular public health concern, as syphilis during pregnancy can cause congenital syphilis, which may result in serious birth defects and stillbirth, and that's something that everyone's very concerned about. For the first time since 2004, congenital syphilis has re-emerged in Victoria. There had been no cases since 2004. And there were 2 cases in 2017 and a further 2 cases in 2018. 2 of those cases resulted in fetal death, which is really very sad because it's something that's absolutely preventable. And we can be testing for this. And we do test for it antenatally, but sometimes it depends on whether the person who's having a baby has actually missed any antenatal screening. Syphilis rash. Beware the rash that doesn't itch. Now, this is not always the case, but often people with syphilis will have a rash that isn't itchy. This photo here is a very extreme case, but we usually see a syphilitic rash on the torso, sometimes on the soles of the feet and the palms of the hands. Syphilis rash. Beware the rash that doesn't itch. Now, this is not always the case, but often people with syphilis will have a rash that isn't itchy. This photo here is a very extreme case, but we usually see a syphilitic rash on the torso, sometimes on the soles of the feet and the palms of the hands. Syphilis, testing and treatment. So for syphilis testing, if someone came into Melbourne Sexual Health Centre and they had a chancre, we'd be taking a swab from their chancre. We also do syphilis serology, however it does have a window period of up to 12 weeks. We usually say syphilis can show up between 9 and 90 days. People who do show up positive syphilis markers on their blood test, on their serology, may not need to be treated, as this may have been a past adequately treated infection. As I said before, if you do need help interpreting syphilis results, you can ring Melbourne Sexual Health Centre and speak with one of the doctors on the sexual health advice line. But gathering a comprehensive history is also very helpful, as a patient may disclose to you about a past syphilis infection. Syphilis is included in routine STI screening for core groups such as gay men or men who have sex with men, but it's now also recommended for women as well. As I said before, it is included in antenatal testing in pregnant women too. The treatment for syphilis is a benzathine penicillin injection. It's 1.8 grams, and that's split into 2 syringes, and 1 in each bum cheek is given intramuscularly. Depending on the stage of syphilis, it's either given as a once-off dose, or it may be given weekly for 3 weeks if late syphilis is suspected. If the patient who's positive for syphilis has a penicillin allergy, they can be given doxycycline for 2 to 4 weeks. But the benzathine penicillin is the preferred treatment. Again, the patient should be having no sex for 7 days after treatment, and this includes oral sex as well. Mycoplasma genitalium, or MG. Mycoplasma genitalium is something that wasn't tested for a lot, but it's certainly being tested for more now. It's a bacterial infection that can infect the urethra, the cervix, the throat and the anus, and it's transmitted by condomless vaginal, anal and oral sex, or when a condom isn't used properly. There are a few studies to tell us how common MG is, but it is difficult to assess as it's not a notifiable infection and it's not routinely screened for in asymptomatic patients. It is associated with pelvic inflammatory disease and it's a possible cause of infertility as well. A lot of the time, Mycoplasma genitalium infection is asymptomatic, but it can cause Cervicitis in women and urethritis in men. Although it's not a notifiable infection, contact tracing should definitely be attended. Mycoplasma genitalium testing and treatment. So with testing for MG, we only test if a patient is symptomatic. We don't include an MG test in our usual asymptomatic screening of patients. For testing, we would usually do a first pass urine for men and women or a cervical swab using PCR. If the patient presents with any rectal symptoms, we would do a rectal swab. We also test for MG if someone comes in as a contact of MG, even if they're asymptomatic. When we're looking at the treatment for MG, the type of treatment given is dependent on what type of MG the patient has. So they'll either have macrolide sensitive or a macrolide resistant MG, and that will show up on the result. If they have macrolide sensitive MG, they'd have doxycycline 100 milligrams BD for 7 days and then azithromycin 2.5 milligrams for the first day, followed by 3 days of 500 milligrams. If they had macrolide resistant MG, they would start with doxycycline 100 milligrams BD for 7 days and then have moxifloxacin 400 milligrams daily for 7 days. The patient requires a test of cure 4 weeks after commencing treatment and is advised not to have sex until they return a negative test of cure. MG can be a really tricky infection to treat, particularly the resistant form of MG. If you're wondering about what sort of treatment your patient with a positive MG result should have, you can go onto our website and see all our guidelines for the treatment of MG. That brings us to the end of all the bacterial STIs. We're now going to move on to viral STIs. The human papillomavirus, or HPV. HPV is often known as the common cold of STIs, and that's because most people who are sexually active will come into contact with it at some point in their lives. There are about 40 different types of HPV that affect the genital and reproductive system. We are seeing less and less of this since the Gardasil vaccination commenced. HPV is most commonly associated with genital warts or abnormalities in cervical screening. For a large majority of the time, HPV is usually asymptomatic, and so when we're seeing people come into the clinic that present with warts, they're really in the minority. There are many people that have the wart virus but don't have any symptoms, so they just don't know that they've got it. It's spread by direct skin-to-skin contact during sex or sexual contact, so it doesn't have to be penetrative sex to spread the virus. Transmission from mother to child or vertical transmission during birth is rare, and there is a long latency in self-clearance over time. So you know the virus is going to go away on its own eventually, but it can be there for quite a long period of time, and this distresses some people. HPV is not a notifiable infection. HPV and genital warts. So these are growths or bumps that appear on the vulva, in or around the vagina or anus, on the cervix, on the penis, on the scrotum, or on the groin or thighs. They can be large, small, flat, raised, single or multiple, and they really vary in their appearance between patients. We know that 90% of genital warts are caused by type 6 and type 11 of the HPV virus, and those two strains are two of the strains that are covered in the HPV vaccination. Hence why we're seeing less genital warts now. Warts may appear within several weeks after sexual contact with a person who has the virus, or they may take months to appear, or they may never appear. So this can be tricky if you're seeing someone present for the first time with genital warts in the clinic and they want to know exactly who it is that's given them the virus. Really, it's impossible to know, and it's not something that we can answer for them. In terms of treatment, genital warts can be treated with liquid nitrogen or topical creams such as Aldara, but this is purely for aesthetic reasons and it doesn't get rid of the virus. So it's actually the patient's immune system that eventually will clear the virus over time. So here are a few photos of how genital warts can appear on different people in different sites of their body. The top right-hand corner is a cervix with a wart on it. I think the other photos are self-explanatory. As you can see, some warts have a cauliflower appearance to them. Other warts are thinner and flatter. Some appear in multiple groups, or some just one individual wart by itself. These are some normal anatomical variants that sometimes people come into the clinic worried that they have warts. So the picture on the left is just sebaceous glands, which are normal, and on the right, pearly penile papules, which are small spots around the head of the penis. Often people come in thinking that they have warts, but they're not warts. So it's important that you can show people that they're actually a normal anatomical variant and they needn't be worried about them. HPV and cancers. So there are some types of HPV that are considered high risk and they can be cancer causing. So they can cause cervical cancer and some vaginal and vulval and anal cancers. HPV type 16 and 18 are responsible for the majority of cervical cancers. Now, most women clear the virus naturally and don't go on to develop cervical cancer. It's only when these types are not naturally cleared that they can go on to cause cancers. And this is why cervical screening is incredibly important, so that we can get to this early and we can monitor these people and treat them if necessary, and therefore it doesn't become cervical cancer. There also is an increased incidence of anal cancers in people living with HIV, and the Gardasil vaccination is given to men who have sex with men, or just men in general now at school as well. The cervical screening test is a screening test, so it's not diagnostic. It looks for changes to cells on the cervix. Cervical cell changes proven by biopsy and an HPV DNA test can be treated by laser therapy under an anaesthetic to reduce the risk of cervical cancer. HPV prevention equals vaccination. The new type of Gardasil vaccination, known as Gardasil 9, prevents HPV type 6, 11, 16, 18, 31, 33, 45, 52 and 58. And that will protect people who have never been exposed to those types of HPV. Under the National Immunisation Program, Gardasil is free for girls and boys in high school in age groups 12 to 13. And if you didn't get it in high school and you don't fit into that category, you can purchase it at your own cost. Herpes simplex virus, or HSV. So HSV is one of the most common infections throughout the world. There's two different types of HSV, HSV1 and HSV2. HSV1 usually prefers the face, and we say 2 prefers the genitals. However, we know that more than 50% of initial genital herpes episodes are caused by type 1, and 20% of adults have evidence of HSV type 2 infection as well, with 70 to 90% of us having evidence of HSV type 1. It does cause lifelong infection with the potential for reactivation or reoccurrence, and it's transmitted by direct skin-to-skin contact, including with oral sex. Vertical transmission is rare but dangerous during birth. The infection resides in a latent state in the nerves that supply sensation to the skin. It's not a notifiable infection, and like with genital warts, contact tracing isn't required. There is a real stigma associated with genital herpes, and we find many clients want to talk about how this can be discussed with their current or future sexual partners. HSV and symptoms. We can break HSV symptoms into two different categories. First presentation or initial infection, and reoccurrences. Here are some examples of what herpes can look like. So they have a more blistery type lesion and look quite different to the wart virus or HPV. HSV and possible complications. Here are some possible complications that people may have with HSV infection. Herpes simplex virus testing and treatment. The best test we can do is a swab from a blister or ulcer, and that's a NAT test. We don't screen asymptomatic people with serology tests. That's definitely not recommended, as the test is not accurate and it's not specific to the site of infection. In terms of treatment, it's best to start early, and this will shorten the duration of the outbreak and also the severity of the symptoms. We treat with valcyclovir 500 milligrams or acyclovir 200 milligrams BD for 7 to 10 days for a primary episode, plus Panadol and lignocaine if required. For ongoing management, people can either treat each episode as the outbreaks occur, or they can go on suppressive treatment. Molluscum contagiosum. Molluscum contagiosum, or MC as it's sometimes referred to, is a common skin infection. It's transmitted through skin-to-skin contact, and most often it affects infants and young children, but in adults it's usually transmitted during sex. Molluscum are small clusters of round bumps that often have a waxy pinkish look with a small central pit, and you can see these in the pictures here. They clear naturally over months to years, so very similar to the wart virus, and it's your immune system that will get rid of it over time. They can be treated with liquid nitrogen or topical creams, but again, this is only for aesthetic reasons. So it is your immune system that clears the virus. HIV. HIV is a virus that affects the immune system, and it does so by destroying certain cells within the immune system called CD4 cells. Eventually, the damage to the immune system is so severe that the body can no longer compensate and cannot stop some infections or cancers that would usually fight off. These are called opportunistic infections, and they're not usually seen in healthy people. HIV is very much a chronic and manageable disease when on antiviral medication. HIV is diagnosed by a blood test known as an antibody test, which has a window period of 6 weeks, which means that it takes HIV 6 weeks to show up in the blood. It is a notifiable infection, so the Department of Health certainly need to know, and contact tracing is definitely required. We will chat further about PEP and PrEP in the coming slides. This slide shows the groups of people being diagnosed with HIV from 2010 to 2014. As you can see from the graphs, the majority are male-to-male sexual partners. So there's the Indigenous and the non-Indigenous groups, but both of them, the most of HIV infections are in the male-to-male sexual contacts. PEP stands for post-exposure prophylaxis, and it's the administration of antiretroviral medication for 28 days. If a person is in contact with someone who is HIV positive, or they've had some high-risk sex where they think there's a chance that they've been in contact with HIV, then they can commence some PEP medication and needs to be started within 72 hours of the possible exposure to HIV, and it's given for 28 days and needs to be taken every single day. It's given to those at risk of HIV transmissions and needs to be given as early as possible. And there are some guidelines around who should be given PEP, and I've included those at the bottom here under the ASHM guidelines. What is PrEP? So PrEP stands for pre-exposure prophylaxis. So different to PEP, which is post-exposure, this is pre-exposure prophylaxis. So the goal of PrEP is to help prevent HIV infection if you're exposed to HIV. People who are on PrEP take 1 tablet daily, ongoing, for example, Truvada. PrEP and Medicare. PrEP is currently listed on the Medicare PBS for use. However, people who don't have a valid Medicare card in Australia can go onto the PAN website, which I've listed at the bottom here, which gives them useful information about how they can access PrEP and buy it online, or they can use the PrEP Me clinic at the Alfred, which is for non-Medicare card holders. There are some potential side effects of using PrEP, and I've listed these below. However, most of the time PrEP is usually well tolerated. There is ongoing management required for someone who's on PrEP, and this is listed below. Resources for PrEP. Please see the following resources listed below for any extra information you might like on PrEP. The remaining 2 slides include a summary of today's presentation. I'd like to thank Carly Schreiber for the slides provided for the presentation today. Thank you.